Hi, everyone, and welcome back to the Egg Whisperer Show. I'm Dr. Amy, and today I am so excited to be joined by a true pioneer in the world of fertility medicine, Dr. Sherman Silber. Today's focus is on breaking fertility barriers, mini IVF, IVM, and the future of reproduction. Dr. Silber is world renowned for his groundbreaking work in infertility and reproductive biology. He has helped develop techniques like mini IVF, ovarian tissue transplantation, and in vitro maturation of eggs. I know that's a lot of words there, but we're going to break it down today. These innovations have changed what's possible for so many patients around the world. And I have been following Dr. Silber since I was a medical student. We're going to talk about some of these exciting advances today and what they mean for you if you're thinking about your fertility journey, planning for the future, or exploring new options. So let's jump in. Dr. Silver, welcome.
Thank you very much, Dr. Amy. I really do appreciate this opportunity to be with you.
Thank you. Well, let's start with something many patients may not be familiar with: in vitro maturation, also known as IVM. Can you explain what IVM is and how is it different from traditional IVF?
Well, with traditional IVF, of course, we stimulate the women with hormones. And in order to get more follicles, because you don't want to just get one egg and go through multiple cycles, because the majority of human eggs aren't going to be a baby. So you like to get multiple eggs, maybe 10 eggs, 15 eggs. You like to get more eggs if possible, so that she only has to go through one cycle to get embryos that'll result in the baby. And so you give hormones for that. Actually, what we found is you don't have to do that with all cases. We discovered that with our ovary freezing for cancer patients, that we can dissect that ovary and we find these immature eggs that haven't been stimulated, have been subjected to hormonal stimulation. And so they're no good in their present form. And you can even retrieve them with a tiny needle for patients with PCOS, particularly. And then we can mature them in vitro. In other words, we can make these immature eggs we call GVs. You don't have to remember that, but we can actually mature them into these what we call M2 oocytes that we normally get when we stimulate a woman, retrieve her eggs for IVF. So we don't need hormonal stimulation. And in fact, when we take out an ovary to freeze it for a cancer patient to preserve her fertility, we can preserve not only ovary tissue, we can preserve these eggs, we freeze these eggs as well that are all ready for IVF without any hormonal stimulation whatsoever.
Yeah, that's incredible. And I feel like so many eggs are discarded and wasted in this country every single day because other clinics are not giving eggs a chance that could potentially be used for IVM.
That's exactly right. We have a motto, give every egg a chance. And the IVM is remarkably good. And we based our approach on experimental work that we did with the Japanese, with Dr. Hayashi, making eggs. It was in mice, but it works in humans too, in taking skin cells from the mother's tail cell and converting them into stem cells and converting the stem cells into eggs. So that's very complicated. But we learned from that the simplicity of IVM, and actually IVM is very simple. If any clinic wanted to take our recipe, anybody could do it. It's not technically difficult to do.
That's wonderful that you're also willing to share. I love what you said. What did you say? Give every egg a chance?
Give every egg a chance.
Yes,
Yeah,
yeah. My clinic's like slogan is no egg left behind, but I actually like yours better. Give every egg a chance. Sounds way
well,
better.
I
I think
actually
I'll
like
steal it.
yours. Leave no egg
Yeah.
behind.
No egg left behind. So you mentioned about the tail of a mouse. Okay. Isn't
Yeah.
that what you just said? And so people are probably like, what are you talking about? And I think that takes us to our next topic that I would love to dive into with you is is there hope from skin cells? And what I'm talking about is this exciting idea in fertility science. And so many of my patients in the Bay Area ask me about that. And this is in vitro oogenesis, which is the possibility of making eggs or even sperm from skin cells. And it sounds like science fiction. Can you tell us how close are we really to being able to do this? And what does this mean for patients?
Well, I work very closely with the Japanese basic scientists and also with Amanda Clark at UCLA in Los Angeles in America. And the leader in England is Dr. Sarani, who trained Dr. Hayashi, but he's retired, Dr. Sarani. So it's mostly coming from Dr. Hayashi in Japan. And I can tell you what he is embarking on and why it will work. He believes in 5 years we'll be able to do this in a human, totally successful in the mouse. However, it'll take another 5 years of regulatory review before we can really be okayed by the regulatory agencies to do this in humans. But we'll be able to do it in humans probably in 5 years. We already are able in the human to make what we call PGCs from skin cells. Skin cells to stem cells, that's easy to do in humans. That's everybody's doing that. But then making the stem cells, turning these stem cells into PGCs, which means primordial germ cells, which means you're sort of halfway there making the eggs. And we can make PGCs very successfully because we know exactly what genes and transcripts to incubate the stem cells in. So the next step really requires fetal ovarian somatic cells or granulosa cells. And a layman may not know what I'm talking about, but the cells that normally support the egg in the ovary. In order to convert these PGCs into competent oocytes that will make a baby, you really need fetal versions of these cells, not adult versions. So now in the mouse, we can make these fetal versions of these cells just with different transcripts. And so we have baby mice that just have come purely from with nothing but stem cells, and the baby mice coming from mothers who had no ovaries. And we have PGCs now on many women who are over 50 who are out of eggs. And these are young PGCs. They're fetal PGCs. So when we convert them into oocytes in 5 years, they'll be very, very young eggs. And so I make this outrageous statement that in about 10 or 15 years, when the regulatory review is completed, a 38-year-old woman would be better off having a skin biopsy than an egg retrieval.
Early in my career, I used to say, and I still do, but I look forward to the day that no woman will ever have to go through egg freezing. No
Yeah.
woman will ever have to use an egg donor or even a sperm donor. And this could completely revolutionize how we do IVF and what we offer patients. It'll be extraordinary. I hope that I can see that day. And I've been saying that, and I used to say, I'll never see that day, but it sounds like we will.
Well, I think we will. And you mentioned sperm donor. Yes, in men without sperm, it's the same thing. We have PGCs from azoospermic men coming from their skin biopsy. So it's the same type of process to turn those PGCs in the male into sperm.
Yeah. And do you see the US government supporting these kinds of technologies, or do you think I should set up a clinic in Honduras to help patients with it? I'm totally serious because I have these thoughts like middle of the night, and I start going to ChatGPT and I ask ChatGPT like, where's the best clinic for me to set up overseas to offer patients experimental therapies? Do you think that all the fertility clinics will be able to do this?
It won't be right away. In the early days of IVF, which was in 1979, we didn't really have widespread use of IVF until about 8 years later. In other words, fertility doctors in 1984, everybody was struggling. They didn't know anything about cell culture. And it took a while into the late 80s before IVF really became popular. So it was like almost 10 years later. And so that'll be the same with this. I think eventually every clinic will be able to do it because, frankly, the genes, the transcripts that we use to do these conversions to stem cells into eggs, you can purchase all of them. They're all for sale, they're commercially available. So you can make the media.
I want to talk about another topic that you've really pioneered. I mean, you made mini IVF an option for patients because of what you pioneered. And I would love for you to talk about mini IVF, how you came up with it, and how it works, and why it might be a better option for some patients.
I think it's a better option for all patients, and I'll explain it. It came out of our work with ovary transplantation in the humans and was the in vitro production of eggs in the mice. The way it works is we discovered that all your eggs in your ovary it are always exposed to pituitary hormones, the stimulatory hormones, but in modest amounts. And that's all that's necessary to really mature the egg and make it a good egg. And the way it works is almost all of your eggs are in a resting phase, as you know, in the outer membrane or cortex, the outer shell of the ovary. And they're recruited on average 30 a day from this resting phase, and they go through 4.5 months genetic development that is not sensitive to hormones. And it's like the far side of the moon. We really don't know what, well, now we're finding out what's happening. We need to. But it's 4.5 months of this strange, inexorable process where the eggs are getting ready to be sensitive to hormones. And then 4.5 months later, they emerge from that phase and they enter the ovulatory menstrual cycle. We discovered that less than 7 days of exposure to the pituitary hormone, and the eggs will never mature, no matter what you do. And more than 12 days of exposure to these pituitary hormones, and those eggs will probably degenerate. They won't be very good. So there's a sweet spot of 7 to 12 days of exposure to pituitary hormones that prepare them for becoming fertile and mature. So once we knew that, we realized that you want to synchronize when you stimulate to when eggs are first emerging from this resting phase. So it's very simple. We put them on birth control pills, and that's a minimum of 18 days. You could do it with some other method like an antagonist like ganirelix. But what you want to do is just clean out all those eggs that have had some exposure already to pituitary hormones, so that when you stimulate, all you're getting are eggs that same day you started the stimulation, that's the day they're becoming sensitive to the hormones. And we found is you don't really need much. You don't need very much of this stimulation like FSH. All you want to do is really create follicles so you can retrieve the eggs. I'll make an extreme statement. The only reason for a follicle is to make it easy for us to stick a needle in and get an egg.
That's true.
So a very low dose will get the same number of eggs with a low dose of stimulation FSH as we would with a high dose. We've known for decades from work from Europe, from Holland, that high doses of the hormone will actually create a higher incidence of genetic abnormalities we call aneuploidy. And so a high dose of FSH, frankly, is going to ruin most of the eggs. And so 3 things. Suppress first with birth control pills so you can synchronize the stimulation. Second thing is low dose of FSH, and it'd be like 150 IU every other day. And the third thing is you need LH for egg quality. That's really important. We found with in vitro work in the mouse that I was telling you about, if you don't have some LH, it's very inefficient. How do you get LH? Well, we can't give it exogenously because it's got a 1-hour half-life, and so nobody makes it. We can't buy it. So we give them that 70-year-old drug, Clomid, in a low dose. You don't want a high dose of Clomid, just 50 milligrams, that's it. And that will give you the LH slight boost that you need for egg quality. So that's very simple. Those are the 3 basic principles of this protocol. Very, very low stimulation dose. Drug companies hate that because they want you to use a higher dose. But the low
Absolutely.
dose will give you a better quality
Yeah.
egg.
So what do you consider high dose? Because I have patients that come to me, second opinion consults, like I'm sure you get all the time. And then they ask the question, do you think that I was on too much stimulation and that's why my embryos were abnormal? So how would you define high doses?
Yeah, it's not exactly a red line, but for example, usually couples, particularly ones that had a low ovarian reserve or difficult cases, are put on 450 IU a day. And actually, 150 every other day would be ideal. You could do 75 a day, but you just reduce the number of shots by doing it every other day because FSH has a long half-life.
Yeah.
Anytime you get up to 300 or 450, you're really harming a lot of the eggs. Not all of the eggs, but
Right.
you're reducing the number of eggs that are fertile.
Right. And I agree with that. I see that too, where patients have a follicle count of 5 or less, and they're pumped with these high doses of medications for absolutely no reason. It doesn't
Yeah,
make any sense to
it
me.
doesn't increase the
No,
number of eggs, it just ruins the eggs.
exactly. And you emphasize with mini IVF that, you're focusing on the quality, not just the number. Why is it that fewer eggs can sometimes mean better chances of success?
Okay, we don't mind getting a lot of eggs. The
Right.
point is you don't want to get a lot of eggs by stimulating with a high dose of hormones. So there can be women with a very good high ovarian reserve, and you give a little Clomid, 50 milligrams, and 75 of FSH, and you might get 15 or 20 eggs if they have a high ovarian reserve, and that's just fine. I'd love to get more eggs, but not because they've had too high a dose.
Right, right. So I want to talk a little bit about ovarian transplantation because you're a pioneer in this too. But I'm going to throw out a scenario to you. Do you see a time when a woman in her 30s who hasn't started her family has a laparoscopy to freeze her ovary for later transplantation? Do you think that that would ever be a thing?
Ovary freezing I think, is a really good method of fertility preservation, and it's the only method I'd recommend for cancer patients. But for women who just want to preserve I still recommend it even for women who just want to preserve their fertility for later. I can explain why. However, if they're not a cancer patient who are about to undergo sterilizing chemo and in the next month are about to be sterilized by their cancer treatment, they really aren't excited about going through surgery and removing an ovary. Now, there's no reason to be afraid of that because studies from Japan, again, have shown that if you take an ovary out of a woman with two normal ovaries, you're just hastening menopause by only 1 year. Instead of the average age of 51, the average age in a population of women who've had unilateral removal of an ovary would be 50 instead of 51. So you're really not, and you're definitely not making her less fertile. So I think it's perfectly good idea to remove an ovary and freeze it for a woman that wants to preserve her fertility. And I think that's, instead of getting maybe 10 or 15 eggs, you're going to get 100,000 eggs. I don't know that it's ever going to be popular
Yeah,
because egg freezing is non-surgical.
right.
You go through hormones and you go through multiple cycles and it's miserable, but taking out an ovary sounds too formidable. But for cancer patients, it's not formidable. They know they're going to lose everything. Let's take out an ovary and we leave the other ovary in. And the reason is we want to, in the future, transplant the ovary tissue back to the other ovary because it's perfectly positioned for the fallopian tube to pick up the egg. And what we're aiming for is spontaneous pregnancy rather than an IVF pregnancy when we do an ovary transplant.
Yeah, yeah. Oh, that is so
And now
cool.
recently, we've started in the last several years doing ovary allotransplant. And that means not just a woman's own ovary and not just an identical twin, but a sister, not an identical twin sister, or a cousin, or even someone unrelated. And the immunosuppressive methods now are so safe that we're using that we're happy to do this immunosuppression even for non-life-saving procedures because it's very, very, very safe.
So my mind's blown. So you're talking about basically like an organ transplantation,
Yes.
but the ovary is not coming from, you're not your own donor,
Right.
basically. You're not your own organ donor.
And it's for many religions, egg donation is not allowed. They feel it's someone's having someone else's baby and it's
Mhm.
third party, and they don't like it. And many people just don't like the idea of it anyway. So a perfectly good option is to transplant an ovary because then she's ovulating inside her own body and no one's fooling anybody. I mean, it's not her DNA, but it really doesn't matter because she's making the egg herself. It's being made within her body. The religions are happy with it, that would be against egg freezing, and many patients really prefer that idea.
This is so exciting. So how long can frozen ovarian tissue last once it's transplanted back?
Well, that's a good question because we're only going to transplant back about 1/4 of the tissue at a time. We're going to freeze the other 3/4. Or we might have frozen it all and we only will transplant about 1/4 of the tissue at a time. And that'll last about 10 or 12 years. We've discovered that follicle recruitment is strictly pressure mediated. And the higher pressure of the tissue in the ovarian cortex is what keeps those follicles at rest. I'll actually talk about that when we talk about actually you and I living long enough to see this actually happen. That's an aside that's interesting. But first, let me just point out that this tissue pressure is reduced when you transplant a piece of tissue. And so you have a massive over-recruitment of eggs. So you lose a lot of eggs in the process of ovary tissue transplantation. And there might be something like 25,000 eggs in that one quarter of the ovary that you're transplanting, and you're losing a lot of them. But it doesn't matter because as the number of eggs goes down, the rate of follicle recruitment goes down. That's why you can take out one ovary and the woman doesn't have menopause any earlier, except maybe 1 year earlier. Because as that ovarian reserve goes down, the rate of recruitment goes down and it keeps the ovary going. But you don't want to do IVF with these pieces of ovary tissue because you're only going to get 1 or 2 eggs. But the woman will be ovulating an egg every month for the next 12 years. So you want her to be able to get pregnant naturally. So that's why we want to put that tissue back where the other ovary that has been killed by chemotherapy is located. So the fallopian tube has no problem picking up the egg. But I just have to mention this aside. When there's high pressure in that outer cortex, those resting oocyte, resting eggs, the nuclei are rotating. And in low pressure, the nuclei are not rotating. And it's a pressure gradient from the outside of the ovary to the inside. And at that point where the nuclei stop rotating, that's where they go on and develop, and they're either ovulated 4.5 months later or they die. So ovarian longevity is related to that tissue pressure that causes nuclear rotation. Now, that is true in all your stem cells in your body.
Wow.
So I recommend exercise for longevity. If you're lucky enough not to get some terrible cancer that might kill you, the way to delay your aging process is a lot of exercise because it creates tissue pressure, myogenic tension, causing your stem cell nuclei to rotate.
Okay. And then what about I know this sounds silly. What about a weighted blanket? Because you're talking about pressure. So if you slept with a weighted blanket, especially over your pelvis, would that help?
I never thought of that. It depends on how that pressure is transmitted inside. But I will say this, that when the woman is pregnant, the ovary goes to sleep. There's no follicle recruitment. That's been shown with the AMH studies. And so women that just keep on having babies just keep on having more babies often. But the increased abdominal pressure of pregnancy prevents follicle recruitment because the entire ovary is subjected to pressure and all the eggs are nuclei are rotating.
Oh, that's so interesting. Very interesting. So I want to talk a little bit about PCOS and then bring in some of the concepts that we've talked about today, because fertility treatment can be really scary for women who have PCOS. There's always concern about a very scary condition called severe OHSS. So how can IVM or mini IVF make this process safer and less stressful for them?
First, we have to understand what PCOS is. So many physicians are so confused about it, calling it the metabolic syndrome, and there's so much controversy about it, but it's really simple. These are women who are born with too many eggs, and that excessive number of eggs or follicles inhibits the pituitary gland's release of FSH when they would have a cycle. So they don't recruit a dominant follicle, or they recruit it inadequately. It's just not this adequate, huge increase in FSH at the time of menstruation. And the PCOS is just caused by having too many eggs. Now, it can be aggravated for sure by obesity because the fat cells absorb estrogen and release estrogen, and those fat cells thereby can also inhibit pituitary's release of FSH, which should go way up at the time of menstruation. And so you wouldn't recruit a dominant follicle. So if women who are obese lose weight, we may very well see they go from irregular cycles to more regular cycles, and they may even get pregnant spontaneously. But that isn't really the root cause. The root cause is having been born with an excessive number of eggs, which, and when, the proof of that pudding actually is that their cycles are all messed up and irregular until they're in their mid 40s, and then they become regular. And that's because you lose eggs as you get older. And the problem is in your mid 40s, the egg quality is down and they're less fertile. But on the other hand, you start ovulating when you're mid 40s, even with PCOS.
Yeah. Yeah. Thank you for that great explanation. So, you've been studying how eggs develop inside the ovary for years. What's something new you've learned that gives you insight into how we can better preserve fertility or improve IVF results?
Okay. And in fact, I didn't completely answer your question about PCOS, but that's related. So again, mini IVF is ideal because you don't want to overstimulate those ovaries. I mean, that leads to hyperstimulation syndrome. And I think for women with PCOS, they should do mini IVF when they want to have a baby, and they should be on cyclic hormonal birth control when they don't want to have a baby, because the irregular cycles are miserable. And there is a metabolic syndrome that develops from not ovulating, which results in a high testosterone level, which is not really great, causing skin problems, and hypertrophic endometrium leads to a higher risk of cancer of the uterus later in life. So I think it's really important for PCOS to manage it as a woman's health issue, not only as an infertility issue. But I really think the best way right now for improving results with IVF and lowering the cost is the mini IVF protocol we talked about. And particularly if there are PCOS patients, I would also make sure we trigger maturation with Lupron rather than HCG, because it's still potentially dangerous. And I would plan on freezing all the embryos, because you don't want to get pregnant when your ovaries are big, because that could result in hyperstimulation syndrome. So I think mini IVF, Lupron trigger, and really good reliable embryo freezing is important. There is a lot of controversy about genetic diagnosis and biopsy of the embryos, and it's still controversial. If a couple is a carrier of a particular genetic disease or mutation, it's extremely accurate. We were the first ones to do that in the United States for cystic fibrosis in a patient with congenital absence of the vas, and we published it in 1995 in JAMA. And it remains very, very, very accurate. However, routine screening for what we call aneuploidy and euploidy is just plagued with controversial results. We certainly would think it's not a bad idea if a woman has just huge numbers of eggs and a huge number of embryos, but there are going to be embryos you diagnose as abnormal that would have been a baby. And so, particularly unless she has a large number of embryos, I think it's a problem if there's only a small number of embryos. You would throw away embryos that would have been a baby. So that's very controversial, but it may improve in the future. And so I think embryo biopsy and genetic diagnosis is an area of great research. What I'm very excited about is the possibility of if a couple has a family history of a particular disease that we know is familial or genetic, whether it's heart disease or diabetes or high blood pressure, it's possible now at PGTP to actually get a score on the embryo biopsy. So you have some idea, what is the percentage chance that baby is going to have an adult disease that the parents had or the grandparents had when it grows up. And you can reduce that risk by embryo biopsy. So it needs more research, but I think that's really, to me, the most exciting aspect of embryo biopsy.
Yeah. And I think you're one of the first fertility doctors that came out publicly and has been very cautious about interpretation of PGTA results.
Yes.
And that's one of the many things that I've admired you so much about. And so I actually tell my patients PGTA really should be PGTA ambiguous.
Yes.
And
Yeah, that's perfect.
yeah,
Ambiguous. That's right.
ambiguous. Because I think if you were to ask someone who doesn't have a background in this field, what are you screening when you're doing PGTA? A lot of people think that we're screening for autism, birth defects, their baby is going to be perfect and genetically normal, which is not true.
Exactly right. We shouldn't be calling it genetic testing, but all the patients say, you are going to do genetic testing, are you not? And then I have to explain the whole thing to them, whether it's a good idea or a bad idea to them because it's not genetic testing.
Right, right. So let's talk about the future of fertility treatment. If you look 5 or 10 years into the future, what breakthroughs do you think patients might see when it comes to treatment?
Well, the biggest problem, of course, is older eggs and also azoospermia. And I'm very, very confident that we'll be able to make sperm and make eggs in the future, as I said, in 5 years, but with regulatory views, it might be 10 or 15 years away before it's the common practice. But I think that, well, for certainly a 45-year-old woman who has maybe a 10% chance of success, she'd be much better off having a skin biopsy, convert those skin cells into stem cells, those stem cells into eggs, because they will be fetal eggs. You can't get younger eggs. So they'll be you don't need very many of them because they'll be very, very fertile eggs we'll get from the skin cells.
Yeah. And what
And
about for patients, let's say a menopausal woman who, or someone who's perimenopausal and is just having a miserable time with menopause? Is there a role for ovarian transplantation for her? Is it, maybe removing an ovary at 40 and then replacing it at, let's say, in her late 40s to potentially prolong her not reproductive window, but to delay menopause for her as a
well,
potential way of increasing longevity?
the University of Copenhagen in Denmark was the first to suggest that, and is 100% right. You could, if a woman is willing, you could take out an ovary and freeze it. And then when she goes through menopause around age 50, instead of allowing her to go through menopause, you could transplant a piece of that ovary. And it'll last 10 to 12 years. And she doesn't have to be on hormone replacement. It's going to be natural. If she doesn't want periods, it's okay. You can put in a Mirena IUD and she won't have periods. And then 12 years later, you can transplant another piece of tissue. And you don't even have to put that tissue near where the ovary would normally be. You can put it in her arm, really, because it'll work just as well for hormone replacement. And so she could make it easily to age 95 or 100 without ever having to take hormone replacement. And of course, I think it's really, really important for women not to have to go through menopause. And I'm not just talking about hot flashes that'll be over in 3 years, but I'm talking about her overall health, bone health, and vagina not drying up, and recurrent urinary infections, and early onset Alzheimer's. For all those reasons, it's really better for a woman unless she has a real problem like estrogen sensitive breast cancer. It's really very important for her not to be menopausal. And so that may be a more important aspect of ovarian transplantation that you brought up than just preserving fertility. Because if you put women on just pills and hormone replacement, they often just stop taking it. It's a pain. But all you got to do is just slap a little piece of tissue on their forearm, and then for 12 years, they don't have to think about it.
Okay, everyone, you heard it here first. Dr. Silber, I'm going to come to you. I want my ovary removed. I'm 49 years old. I actually still have regular cycles. And we're going to do this experiment together because I want to live until I'm 120. And I also don't want to go into menopause until I'm 90.
I think that's right. I agree with you totally.
So this has been such a delight talking to you today. And clearly, you're a pioneer in this field. And I'm so honored that you spent this time with me today. I want to know, what's your biggest hope or message you'd like to share with patients who are listening to us?
I would really maybe divert from what I've been saying. And the answer to that is this. There are couples where there's no sperm, and right now we don't have a treatment for it. Might not be able to do this for 15 years. There is women with no eggs, or their eggs are no good, and they desperately want a baby. And that's more and more common because people are putting off childbearing until they're older. And their only option is donor eggs, and they're afraid of donor eggs. I'm very, very interested in early childhood development. We've been using donor eggs for such cases since 1986. So we've watched the families grow and the kids develop and grow up. And I'm certain of what I'm about to say, though it might sound controversial. We can easily match for background and appearance with egg donation. What you cannot match for are 5 attributes that are more important: personality, character, intelligence, emotional stability, and bonding with you as mother. Now, those 5 attributes are definitely not in the DNA. but they appear very early in the first 2 or 3 years of life. And they arise just like the accent of like a Chinese kid that's brought up in Brooklyn, has a Brooklyn accent. They arise in the first 2 or 3 years of life from how they are interacting with their parents or their caregivers. And so when these kids grow up and we've talked to them, we tell the mother, it's not the mother's very proud the kid just graduated medical school. And I say, well, it's not your DNA, just to challenge her. She says, who cares whose DNA is? It's my baby. In other words, it's their baby. So I would like to dispel the idea that egg donation is spooky and inappropriate.
Thank you for that. Yeah, I think there's a lot of shame that patients feel when they even start thinking about it. And I always tell patients the one regret that my patients have when they've had their egg donor baby is that they didn't do it sooner,
Yeah, right. Exactly right.
right?
They wish they had done it sooner. Now, everybody wants their own DNA, and that's why we struggle to do that. But if they can't have their own DNA, because then rationally, a donation it will make them happy.
Yeah. Yeah. Thank you for that. Dr. Silber, thank you so much for joining me today and sharing your wisdom, experience, and hope with us. Your work has opened the doors for so many families and has been an inspiration to me in my career. And I know our listeners will take away a lot of encouragement from this conversation. And to everyone tuning in, thank you for joining us. Don't forget to subscribe to the Egg Whisperer Show on YouTube and follow the podcast on Apple or Spotify so you never miss an episode. I'll see you again soon.